Hi everyone, good day. Welcome to Activity 9. Today we are going to discuss about hematocrit or the packed cell volume, and we will also be including in our discussion the computation of the different RBC indices such as the MCV or the mean cell volume, MCH, mean cell hemoglobin, and MCHC or mean cell hemoglobin concentration. First, we define what is hematocrit. Hematocrit is used synonymously with packed cell volume to denote the percentage of red blood cells in a known volume of whole blood. It is a total volume of erythrocytes in a given volume of blood divided by the volume of blood. Our hematocrit has other names like packed cell volume or erythrocyte volume fraction. When we report our results for hematocrit, we express them in percentage or in percent, which is the conventional unit, or in liter per liter, which is the SI unit. For example, if a patient has a hematocrit result of 25%, that means that there are 25 milliliters of RBCs in 100 milliliters of blood. The principle behind the determination of a patient's hematocrit is based on a collected blood sample from the patient using a hematocrit tube. The hematocrit tube is placed inside a centrifuge to determine the maximum packing of the red blood cells. When the whole blood is centrifuged, the blood components are separated based on their density. So that means that the red blood cells will have to settle at the bottom of the capillary tube since they are heavier as compared to the liquid portion of the sample, which is plasma, which can be seen on top of your red blood cells. After spinning the capillary tube inside the microhematocrit centrifuge, this will be the order of the packing of the different layers of our sample. So we can see that our red blood cells have settled at the bottom of our capillary tube, followed by the buffy coat, which contains our white blood cells and platelets, and finally the liquid portion of our sample, which is the plasma. So always remember that the heavier particles will have to settle first, then followed by the lighter components of our blood sample. There are two known methods for the determination of a patient's hematocrit. These are the macrohematocrit and the microhematocrit methods. Between the two, the microhematocrit method is more commonly used or more routinely used because the macrohematocrit method has a lot of disadvantages as compared to the microhematocrit. These disadvantages include the time it takes for spinning the sample, the amount of sample needed for the procedure, and the presence of trapped plasma, which are not seen in the microhematocrit method. Although the two methods differ from each other, the principle of the test remains the same for both. For macrohematocrit method, the patient sample is contained inside a Winthrop tube, which is the same tube used in the determination of the patient's erythrocyte sedimentation rate. A Winthrop tube is a narrow glass tube measuring 110 millimeters long with graduations from 0 to 100 in both ascending and descending order. For this procedure, the method would require the use of a Winthrop hematocrit tube, a centrifuge machine, and a pasteur pipette. Blood is filled in Winthrop hematocrit tube up to the 100 millimeter mark by the help of a pasteur pipette. The sample is then subjected to a centrifuge machine for 30 minutes at 2,000 to 3,000 revolutions per minute. Take note that the Winthrop tube contains an anticoagulant in the form of double oxalate. When reading the hematocrit results using this method, PCV is read from the scales or graduation seen on the tube. In terms of the disadvantages brought about by this method, we have three disadvantages as mentioned previously, and that includes that the method is time consuming because it requires 30 minutes to spin the samples. Second, it requires a large amount of specimen. And third, there is presence of trapped plasma in between red blood cells for the reason that the tube being used for this method is bigger compared to the tube used in the microhematocrit method. This is how our Winthrop tubes look like when used to determine the hematocrit results of our patient using the macrohematocrit method. Notice that the tubes have graduations or markings. The scale with the markings from 0 to 100 starting from the top going downwards is used in the ESR determination. Whereas if the markings from 0 to 100 starts from the bottom going upwards, it is used for the hematocrit or packed cell volume determination of our patient. Another method for the determination of the patient's hematocrit is through the manual hematocrit method, or also known as the microhematocrit method. For this method, we make use of an anticoagulated blood sample that is placed or collected using a long capillary tube and subjected to centrifugation using the microhematocrit centrifuge, after which the level reached by the column of red blood cells is read with a scale reader, which comes in the form of a rectangular or circular reader. This method is more preferable than the macrohematocrit method because of the following reasons. Number one, it's quicker to perform. Number two, lesser blood samples are required from the patient. And number three, there is lesser centrifugation time. Blood can also be derived directly from the skin puncture of a patient. The samples that can be used for this method are the following. We can use the capillary blood obtained through skin puncture that is transferred to an anticoagulated capillary tube. The anticoagulant commonly used here is the heparin, which is contained in the red band capillary tube, or we can also make use of an EDTA anticoagulated blood sample that is transferred to a non-anticoagulated capillary tube, usually the blue band capillary tube. When performing the microhematocrit method, it is important to note that when filling the capillary tubes with a patient sample, the tubes must be 2/3 or 3/4 full. There should also be no spaces or bubbles seen in the capillary tube. For the clay plug, the length of the clay plug after sealing must be at least 4 millimeters long. In terms of centrifugation, the tubes are subjected to a speed of 10,000 to 15,000 gravity for 5 minutes. The results of duplicate hematocrit determination should agree within plus minus 2%. We should also remember when to appropriately use our colored capillary tubes. For example, the blue banded capillary tubes are used when the sample is directly obtained from an EDTA anticoagulated sample, since the blue banded capillary tubes are non-heparinized or non-anticoagulated. For the red and green banded capillary tubes, these tubes are used when we obtain the sample directly from a skin puncture of the patient. The red band capillary tube contains the anticoagulant sodium heparin, whereas the green banded capillary tube contains the anticoagulant ammonium heparin. Please remember that we are not going to use the red or green capillary tubes when we obtain the sample from an EDTA anticoagulated sample, since the presence of the anticoagulant in your capillary tube can cause dilution of the sample. The following are some of the technical errors encountered when performing the hematocrit method. The technical errors are divided into three. We have the decreased hematocrit levels, the increased hematocrit levels, as well as the decreased or increased hematocrit levels. Under the decreased hematocrit levels, these are the following reasons. We have the use of excess anticoagulant. An increased concentration of anticoagulant decreases the hematocrit reading as a result of erythrocyte shrinkage. Next, we have improper sealing of the capillary tube. Improper sealing of the capillary tube causes a decreased hematocrit reading as a result of loss of blood during centrifugation. A higher number of red blood cells are lost compared to plasma. Third, we have excess centrifugation time. And lastly, we have heat sealing of capillary tubes. The heat of the flame will make the blood move toward the opposite tip. Excess heat will cause the blood to shoot out of this end. Then we have the increased hematocrit levels. The errors listed under the increased hematocrit levels include inadequate centrifugation, wherein the time and speed of the centrifugation and the time when the results are read are important. Insufficient centrifugation or a delay in reading results after centrifugation causes hematocrit reading to increase. Another error listed under increased hematocrit level is including a large buffy coat in the reading. The buffy coat of the specimen should not be included in the hematocrit reading because this falsely elevates the result. For the decrease or increase hematocrit levels, we have two technical errors listed. First is insufficient mixing of the sample, which depends on which part of the specimen, either the plasma or the red blood cells, is principally drawn into the microhematocrit tube, and improper use of the microhematocrit reader. It is important to note that as a laboratory scientist, you should be able to practice the skill of reading hematocrit results using the rectangular or the circular microhematocrit readers. The following are the physiological errors related to hematocrit. First, we have trapped plasma, which is the small amount of plasma that remains in the erythrocyte portion of the spun hematocrit. Many disorders such as sickle cell anemia, macrocytic anemias, hypochromic anemias, spherocytosis, and thalassemia may cause plasma to be trapped in the erythrocytes layer even if the procedure is correctly done. There is a false increase of hematocrit results as much as 1 to 3% or 0.01 liter per liter to 0.03 liter per liter. Another error related to hematocrit is dehydration or fluid loss. For dehydration or fluid loss, it causes a decrease in the plasma volume and falsely increases the hematocrit reading. And lastly, we have specimen collection errors. Under specimen collection errors, we have hemoconcentration, which is related to leaving the tourniquet for too long on the arm of the patient, which results into a false increased hematocrit result, and difficult venipuncture or skin puncture that introduces interstitial fluid into the sample, which results to a false decrease in the hematocrit result. In this slide, the rectangular reader is being used to determine the results of the hematocrit of a certain patient or individual. Later on in the video demonstration on how this activity is performed, you would be able to know how this device is correctly or properly used. The same goes with the circular reader, which is another device to determine the hematocrit result of our patient. For the reference values for hematocrit, we have our two patient populations, the adult female and the adult male. So for adult female, the normal value for hematocrit ranges from 35% to 49% if expressed in conventional unit. And for adult male, it ranges from 40% to 54%. For the clinical significance of our hematocrit results, let's take a look at some of the conditions or disorders that will tell us why the patient has a decreased hematocrit or increased hematocrit results. So for the decreased hematocrit, we have the following conditions. The patient may be experiencing bleeding because of the presence of ulcers or there's trauma, colon cancer, or internal bleeding. It could also be due to destruction of RBCs because of sickle cell anemia or the enlargement of the spleen or what we call splenomegaly. We also have decreased production of red blood cells due to suppression in the bone marrow, cancer, or certain drugs. We also have nutritional problems due to low iron, B12 and folate deficiency, and malnutrition. We also have overhydration, and that includes your polydipsia or excessive thirst or excess drinking, and you have IV overhydration. For increased hematocrit, this could be the following disorders or conditions that are related to this result. We have patient experiencing dehydration due to heat exhaustion or no available source of fluid, low availability of oxygen, especially in places that are located in high altitude, or if the patient is a smoker. We also have genetic conditions like congenital heart disease and erythrocytosis, or the proliferation or increased production of red blood cells as seen in polycythemia vera. Now we go to the computation of the different RBC indices. Let's start first with the MCV. MCV is known as the mean cell volume or the mean corpuscular volume. In the computation of this parameter, we are going to need a formula in the form of your MCV is equal to the hematocrit, which is expressed in percentage or percent times 10 divided by the RBC count, which is expressed in SI unit. The MCV also tells us the average amount of space occupied by each red blood cell, which is technically the volume of an RBC. The average volume of an RBC is expressed in femtoliters or FL. For the normal value of this parameter, MCV ranges from 80 to 100 femtoliters. Red blood cells with an MCV of less than 80 femtoliters are considered microcytic or microcytes. Those with an MCV of more than 100 femtoliters are considered macrocytic or also known as macrocytes. If the MCV of the cell is between 80 to 100 femtoliters, the cell is considered normocytic or normocyte. Increased results in the MCV would tell us that the patient is suffering from megaloblastic anemia, whereas decreased result in MCV would tell us that the patient is suffering from iron deficiency anemia or thalassemia. Basically, the MCV tells us the size of our red blood cells, and there is a direct relationship between the MCV and the size of your red blood cell, because as the MCV increases, the size of the cell also increases. Another parameter in the RBC indices is the mean cell hemoglobin or the MCH. It's also known as mean corpuscular hemoglobin. This is the average weight of hemoglobin in an RBC expressed in picograms or pg. The formula in the calculation of this parameter involves MCH is equal to the hemoglobin of the patient expressed in grams per dl times 10 divided by the RBC count of the patient expressed in SI unit. The normal value of MCH ranges from 28 to 32 picograms. If the result of the MCH is more than 32, the patient could be experiencing macrocytic anemia. Whereas, if the patient's MCH result is less than 28 picograms, the patient is experiencing a microcytic hypochromic anemia. The last parameter included in the computation of the RBC indices is the mean cell hemoglobin concentration or the MCHC. This is also known as mean corpuscular hemoglobin concentration. It is defined as the average concentration of hemoglobin in each individual RBC. The unit used is grams per deciliter or grams per dl, which was formerly given as a percentage. For the computation of this parameter, the formula is MCHC is equal to hemoglobin of the patient expressed in grams per dl times 100 divided by the hematocrit of the patient expressed in conventional unit. The normal value for this parameter ranges from 32 to 36 grams per dl. Values of normochromic cells ranges from 32 to 36 grams per dl. For hypochromic cells, the value of the MCHC is less than 32 grams per dl, and for hyperchromic cells, the values are greater than 36 grams per dl. Hypochromic RBCs usually occur in thalassemias and iron deficiency anemia. The term hyperchromic does not really mean that the cell contains more than 36 grams per dl of hemoglobin, but its shape may have become spherocytic, which makes the cell appear full. Then we have the rule of three. When specimens are analyzed by automated or manual methods, a quick visual check of the results of the hemoglobin and hematocrit can be done by applying the rule of three. This rule only applies to specimens that have normocytic normochromic red blood cells. The value of the hematocrit should be 3 times the value of the hemoglobin plus or minus 3. It should become a habit for the analyst to multiply the hemoglobin by 3 mentally for every specimen. A value discrepant with this rule may indicate abnormal red blood cells, or it may be the first indication of error. For example, in case 1, the patient's hemoglobin is 12 grams per dl and the hematocrit is 36%. If we want to apply the rule of 3, we are going to multiply the hemoglobin value of 12 by 3, and the answer is 36. An acceptable range for hematocrit would be 33% to 39% if we are going to subtract and add 3 from the hematocrit result. These values conform to the rule of 3. Another example is case 2. In case 2, the hemoglobin result of the patient is 9 grams per dl and the hematocrit result is 32%. According to the rule of 3, when we multiply the hemoglobin result by 3, the hematocrit is 27, but the given hematocrit result of the patient is 32%. An acceptable range for hematocrit would be 24 to 30% because we have to add or subtract 3 in the hematocrit result. So these values do not conform to the rule of 3. Take note that if the values do not agree, the blood smear should be examined for abnormal erythrocytes. So that's it for our discussion on hematocrit and the computation of the different RBC indices. I hope you have learned something from our discussion. Thank you so much for listening and have a good day.